a professor of clinical oncology at Shams University, about his kind invitation and persistent work for continuous medical education. It's the third virtual meeting within a very short area. To have it with colleagues in Saudi Arabia and the Middle East. And thank Dr. Nala for his invitation to me, and welcome Dr. Hussam Hagazi, Professor of Radiation Oncology in Saudi Arabia. In the era of neoadjuvant treatment or total neoadjuvant treatment, I think we are remodeling now inclusion of short course or long course in the management of cancer rectum. He will present us a very nice presentation about short course versus long course radiotherapy in cancer rectum. Dr. Hussam, تفضل.
Thank you very much, Dr. Muhammad and Dr. Ahmed, for this nice introduction. And I'm really honored to be virtually with you today. Hopefully, inshallah, in the next years, we'll make it happen, inshallah, in person. I have a really interesting topic today to present. So I'll be talking today about the long course versus short course radiotherapy in the treatment of rectal cancer. As we all know, that surgery remains actually the most effective curative treatment against rectal cancer. And we know that the introduction of preoperative neoadjuvant therapy, whether a short course or long course radiotherapy, has reduced the local recurrence rate and improved the survival rate. There are actually multiple options where we can offer to our patients with locally advanced rectal cancer with a short course radiotherapy with chemotherapy, or long course radiotherapy and long course radiotherapy with chemotherapy. I'd like to highlight here the importance actually of the multidisciplinary approach in the management of rectal cancer, as we know that surgical oncology, radiation oncology, and medical oncology, as well as the pathology and interventional radiology, are the main cornerstone of in the management of rectal cancer. And we should also put this in mind that each patient is a unique case. So we need to discuss every single detail about our patients with locally advanced rectal cancer in order to come up with a treatment plan for this patient. So before the decisions, actually, we know that the mainstay treatment is the surgery, but before decisions, decisions are really important than incisions. So we don't rush actually for surgery in rectal cancer before we discuss the case and explore all the options in the treatment of this cancer. I'd like here to go back to the history of rectal cancer treatment. So in 1980s, we all know that the surgery was the mainstay treatment of rectal cancer. And here, when I say surgery, it was an non-TME surgery at this time. And it was associated with a high risk of a high rate of pelvic failure and local recurrence. In 1980s, the introduction of post-op chemoradiotherapy, just to help out the incomplete surgery to decrease the pelvic failure and improve the overall survival. In 1982, where Dr. Belhild actually introduced his technique with TME surgery, he was able actually to prove that there is an improvement in the local control and the overall survival only by doing this surgery in comparison with the other surgeries that has been done at that time. After that, in 1997 to 2001, many studies looked at the long course chemoradiotherapy And they associate this treatment to the surgery, for example, in the Dutch trial and the Swedish trial. And the outcome was to decrease the rate of pelvic relapse. However, in 2004, the introduction again of the long course and radiotherapy, where it became as a standard of care at that time with the results of the German trial, they proved a better outcome in local control and the sphincter preservation. So now we have the evidence of the effectiveness and the efficiency of short course and long course rectal cancer. So since 2010, they started to compare head-to-head the short course radiotherapy versus the long course radiotherapy. And the famous studies were the Australian trial, the Polish trial, and the Stockholm trial. The outcome was that equal outcome, however, some studies showed less postoperative complication and higher rate of tumor regression with long course radiotherapy. So at this time, long course radiotherapy is still as a standard of care in the treatment of rectal cancer. In 2019, with the era of the total neoadjuvant therapy, not only in rectal cancer, but also in other site of cancer, they came with the results of the Rapido trial, which we will talk about later, inshallah, in this session. So what about the NCCN guidelines? In 2020, the chemoradiotherapy and the short course is still options actually for the treatment of the rectal cancer. However, short course is always associated with small comment in the NCCN guidelines, where evaluation of this regimen has to be done in a multidisciplinary setting, where they have to discuss all the aspects and the strategies of treatment, whether the downstaging is important in this patient or not. So again, at least in North America, the chemoradiotherapy is still the standard of care until 2020. So let's go back to the evidence behind the short course radiotherapy. This is the landmark study, which is the Dutch trial. 1,800 patients were randomized to TME alone versus preoperative radiotherapy, 5x5, with immediate surgery in 10 days. Mind here that all these patients were resectable, patients with inferior margin less than 15 cm for anal verge, and most of the tumor was in the pelvis with no metastatic disease. The median follow-up for this study was 2 years, and the initial results at 2 years showed that there is actually a significant difference with a benefit in favor of the preoperative radiotherapy plus surgery compared to surgery alone. However, there was no statistical significant difference in overall survival. At 10 years, the persistent statistical significant difference in the local control in favor of the preoperative radiotherapy plus surgery, and no benefit in the overall survival. So what about the long course radiotherapy? Here is the landmark study, actually, which is the German trial conducted by Dr. Klaus Rodel. 800 plus patients were randomized in this study. All of them were resectable disease, less than 75 years, with no metastatic disease. Most of these patients were staged with endoscopic ultrasound, as the MRI was not included as a staging tool in this study. Patients were randomized into preoperative chemoradiotherapy with 50.4 gray in 28 fractions versus post-op chemoradiotherapy with a boost of 5.4 gray. The median follow-up was 4 years, and the clinical outcome showed that there is actually a statistically significant difference in the local control. The local control cut by half actually in those patients who received the preoperative chemoradiotherapy in comparison to post-operative chemoradiotherapy. These outcomes actually were persistent at 10 years as well in the local recurrence. There was no statistical significant difference in the overall survival whatsoever at 5 years or at 10 years. Here, for those who like actually to see it in numbers, local control is 6% in the preoperative chemoradiotherapy versus 13% in the post-op chemoradiotherapy at 5 years. At 10 years, it was 7.1 in the preoperative arm versus 10.1 in the post-operative arm. There was no statistically significant difference in the disease-free survival, distant metastasis, or overall survival. So since then, Dr. Klaus and his regimen is becoming a favorite option, at least in the North America. So what about the chemotherapy? Does it really matter which chemotherapy we're using with the radiotherapy? This question has been answered actually by several studies. One of them is the NSABP R04, where 1,600 patients with clinical stage 2 and 3 rectal cancer were randomized into 5FU, whether with or without oxaliplatin, versus capecitabine with or without oxaliplatin. The primary endpoint at this study was local regional tumor control. As we can see here, there was no statistically significant difference in the local recurrence or disease-free survival or overall survival. Both arms were identical. These are other studies that looked at this question, and they did not show any benefit in the pathological complete response, neither in the local regional recurrence. Some of these studies showed more actually toxicity in the arm of the oxaliplatin with grade 3 diarrhea. That's why the oxaliplatin since then is out of the standard regimen in the long course radiotherapy. So now, what about short course versus long course radiotherapy? Theoretically, we are looking at the short course radiotherapy when we have an immediate surgery. The cost is lower with excellent compliance and probably less acute toxicity. While when we look at the local long course radiotherapy with chemotherapy, probably we're thinking about the delayed surgery, downstaging the tumor, and having a higher rate of PCR, sphincter preservation, probably improved late effects, or watch and wait protocols. Here is the Australian intergroup trial, which is one of the major trials that compared the preoperative radiotherapy with the preoperative short course with the long course with chemotherapy. Around 300 patients were with T3N1 to 2 M0 with less than 12 cm from the anal verge. Patients were randomized into preoperative short course radiotherapy 25 and 5 with immediate surgery in 7 days, followed by 6 cycles of adjuvant chemotherapy versus preoperative chemoradiotherapy 50.4 gray in 28 fractions with surgery in 4 to 6 weeks, and 4 cycles of adjuvant chemotherapy. The median follow-up was around 6 years. There was no statistical significant difference between the local recurrence or distant recurrence or overall survival in this study. Another study, which is the Polish trial, where they looked actually to answer the same question. So 500 patients with more locally advanced disease here in this study, T3 or T4 tumors, less than 75 years. Patients were randomized into preoperative radiotherapy with 25 gray in 5 fractions, followed by four cycles of FOLFOX, versus preoperative chemoradiotherapy with surgery in 4 to 6 weeks. For this study, they actually added the FOLFOX in the short course just to fade away the time factor between the interval between the radiotherapy and the surgery. The median follow-up was 35 months in this study. What was interesting actually about this study, that when you look at the radiotherapy dose, you find that a lot of patients in the long course arm, they did not complete their sessions. And this is due to the toxicity probably of the oxaliplatin. And also for the time of the interruption during the treatment, a lot of patients also in the arm of the long course chemoradiotherapy has been interrupted course of treatment, and thus the time prolongation was due to this toxicity. This could also influence the results of this study. So surprisingly, this study, the outcome of this study showed that there has been an overall survival benefit for the short course radiotherapy arm in comparison with the long course chemoradiotherapy at 5 years. But when we look at this difference at 10 years, we can see that this benefit has been disappeared actually, and both arms are becoming overlapping. The third important study, which is the Stockholm study, this study has taken long actually to recruit patients. So it took from 1998 to 2013, around 800 patients with resectable tumors less than 15 centimeters from the anal verge were randomized into preoperative short course radiotherapy with immediate or delayed surgery versus preoperative radiotherapy with surgery in 4 to 8 weeks. So the results showed that there is no significant difference in the clinical outcome in local control, overall survival, or distant metastasis. But there was an interesting finding here in terms of complication, that postoperative complication was a bit higher in the arm of short course radiotherapy with immediate surgery compared to the delayed surgery. So now we know that both short course radiotherapy and long course radiotherapy, they work well in the rectal cancer treatment in terms of the local recurrence at the pelvis. But the main problem actually of the rectal cancer is the distant metastasis. That's why most of these of the experts actually, they're trying to include the adjuvant chemotherapy in the neoadjuvant setting rather than keeping it after the surgery because of the compliance. So if we look at the traditional approach of the treatment of rectal cancer, we see that chemoradiotherapy followed by surgery and then adjuvant chemotherapy. But in the total neoadjuvant therapy, we have two strategies. Either we start with induction chemotherapy, followed by chemoradiotherapy, and then surgery, or chemoradiotherapy followed by chemotherapy and then surgery. So this is one of the studies that looked at this question. It is a phase 2 trial where they actually added the chemotherapy regimen in the neoadjuvant setting. And they looked at two factors here, the addition of chemotherapy and the longer interval between the radiotherapy and the surgery. The outcome was the more have an interval, the more we add chemotherapy before the surgery, the more the pathological complete response rate is achieved with a statistically significant difference between the four arms. Here we come to the Rapido trial, which is, this is the new era of rectal cancer management. The study started to recruit patients actually in 2013. They looked at the short course radiotherapy followed by neoadjuvant chemotherapy in locally advanced rectal cancer. And this trial was led by Dr. Khoury. So is this the time for change? Rapido study, they actually presented their results in ESMO 2020 this year. Around 900 patients with locally advanced rectal cancer. When we say locally advanced, they chose in this actually trial to have all the patients with adverse features. So T4A, T4B, and N2, invasion of the mesorectal fascia, patients with lateral pelvic lymph nodes more than 1 cm. So patients were randomized into preoperative radiotherapy, short course, 25 in 5 fractions, followed by 12 weeks of chemotherapy, whether FOLFOX or KPOX, versus preoperative chemoradiotherapy. This is the standard arm, actually 50.4 gray in 28 fractions, followed by surgery in 4 to 6 weeks. As we see, the aim actually of this study is not the local recurrence because it's no longer a major problem in the rectal cancer. The aim actually is to test whether this will reduce the distal metastases without increasing in the local recurrence. So the baseline characteristic was equally distributed between the two arms. The high risk criteria as well was equally distributed between the two arms. What we can see here as an clinical outcome that there was more of neurological toxicity, vascular disorder, and GI toxicity in the arm, in the experimental arm with short course radiotherapy followed by chemotherapy. Otherwise, there was no whatsoever surgical related complication, and the types of surgery was equally distributed in the two arms. There was no statistical significance between the two arms. Surgical complications were the same. Actually, this is an interesting result where the pathological complete response in this study showed to be more significant actually in the arm, in the experimental arm, with statistically significant difference. Actually, it was double the rate of the PCR in the standard arm. Also regarding the tumor regression was also toward the experimental arm. What about the disease-related treatment failure? It was also lowered by or reduced by the experimental arm, and it was not to the level of to be statistically significant. However, the distant metastasis showed to be statistically significant with the arm of the short course followed by chemotherapy, and this is maybe due to higher exposure to chemotherapy and number of cycles of chemotherapy received by the patient. However, the local regional failure or local control was almost the same. So when we look at those patients who received who did not receive the adjuvant therapy, which was allowed actually in this protocol, especially for the standard arm, we see that it is actually related with disease-related failure. The overall survival was identical in both arms. So I think now we look at the quality of life at 3 years. There was no statistically significant difference between the two arms, whether in the overall health, overall quality of life, and the low anterior section syndrome. So if we want to conclude, we can say that with the experimental arm, with short course plus chemotherapy, we achieved to lower 7% lower disease-related treatment failure, 7% lower distant metastasis, and doubled the PCR. With 3-year overall survival in both arms were identical. There was no really significant unexpected toxicity in both arms. There was no statistical significant difference in the surgery or postoperative complication and quality of life. So now if we want to choose who's the best friend out of these two experts, probably both of them are my friends, but I think now the winner is Dr. Khoury. Thank you very much.
Thank you, Dr. Sam, about your very nice presentation about this very nice issue. I thank also for this a very good timing to present the short course in our situation in COVID era, because we have a challenge to give the patients a short course protocol without more exposure. I want to open discussion with my question, please, about the designing of the Rapido trial. You know that they include more than 400 patients in each arm. You know that's a standard arm of treatment. The patient did not receive pre-operative chemotherapy. They received concurrent chemoradiation and wait for 8 weeks, then go for surgery. And 180 patients from patients in the standard trial did not receive adjuvant chemotherapy. While in the short course, they adopting a totally new adjuvant treatment. They received concurrent, they received 5x5 fractions in first and followed by 4 cycles of FOLFOX, then surgery. So do you agree with me that standard arm in the Rapido trial is lacking from more chemotherapy? That's why the it's first time to see the PCR is more higher in the short course than long course. Can you explain this issue? Do you think that's a weak point of the trial?
Well, I think this is the reality we are facing now with the patients who are undergoing surgery. Most of these patients, they undergo chemoradiotherapy, and then they wait for like 4 to 6 weeks, and then they go for surgery. I think the compliance is an issue, and it has been demonstrated in many trials that a good percentage of patients, they cannot actually achieve to receive or manage to receive the full protocol with the adjuvant chemotherapy. Another thing that trials who tried actually to test the benefit or to examine the benefit of the adjuvant chemotherapy, they failed actually because of the compliance. That's why I think the total neoadjuvant therapy is solving in part the compliance issue, and in another part, they can achieve actually a better outcome.
So they agree with me that short course radiotherapy should be included in all patients with T4N2 disease, because you know that about 30% of the patient population in the Rapido trial were T4 and 6% were N2 disease. Do you prefer that the short course should be involved before or after chemotherapy in the neoadjuvant treatment, away from Rapido design? You prefer to go for chemotherapy firstly, to downstream the tumor size and give smaller radiation fields in our repractice, or to start with a Rapido trial to give 5x5 fractions followed by 4 cycles of FOX followed by surgery? In the repractice, do you think that some patients with T4N2 disease have a suitable short course upfrontly with very safe fields and very narrow fields to be followed by FOX, or we can go for down staging by FOX firstly, then followed by short course, away from Rapido design?
Yes. What is very important actually in this is a very excellent question actually, and I think it's a debate until now. The problem with those patients with high risk of distant metastases is that we need to start the chemotherapy as soon as possible. And in the era of the long course radiotherapy, we usually prefer to start with chemotherapy as an induction chemotherapy, followed by chemoradiotherapy. But the difference actually in the short course that we only delay the patient for like a couple of days before we start the chemotherapy. So it's only 5 days of treatment, and then the patient is free to receive the chemotherapy. However, in the Rapido trial, they added like 2 weeks in between the radiotherapy and the chemotherapy. But I agree with you, chemotherapy is very important to be added actually in those specific patients. The other thing is, in particular for the patients with N2 disease, or those patients with lateral pelvic lymph nodes. Usually, from the previous studies, we noticed that usually the primary tumor in the rectum responds more to the chemotherapy and to the if it is actually an induction chemotherapy, it responds more than the pelvic lymph nodes. So the pelvic lymph nodes is more resistant actually to chemotherapy. That's why we need to give radiotherapy and probably boost the lymph node.
I have a question from Dr. Nizar about this issue, about lateral pelvic lymph nodes. How do you deal with enlarged lateral pelvic lymph nodes in the short course radiotherapy? I think he asked this question 10 minutes ago. I think you hit this specific problem in the short course, how to cover the lateral pelvic lymph nodes in short course safely without morbidity from radiotherapy. I think you hit this question, Dr. Nizar. I think Dr. Hussam answered your question about free to use either for FOX pre-short course or post-short course. And to me, that is suitable to start with for FOX firstly, away from Rapido design to start with for folks to downstage and to how to minimize your field of radiotherapy as much as you can to avoid radiation-induced complications. And we have now in question from Dr. Musab Siri. COVID-19 makes Rapido acceptable. Otherwise, total neoadjuvant course would be better option. Dr. Hussam, you can answer this question because I think total neoadjuvant treatment can be applied either for short course or long course. Dr. Musab, do you mean that total neoadjuvant with short course or long course or in general?
Yes.
Dr. Hussam, you can answer.
First, greeting to Dr. Mushabbab Asiri. Is actually one of our senior in radiation oncology at the kingdom level, actually. I think total neoadjuvant chemoradiotherapy or total neoadjuvant therapy, whether with the long course or short course, is actually very beneficial for cases where the high risk for metastasis is there. But I think the most important thing is to think about that there is no direct comparison between induction chemotherapy followed by long course chemoradiotherapy versus Rapido protocol, which is the experimental arm, short course followed by chemotherapy. So in order to answer this question, actually, we don't have really the solid evidence, but we can extrapolate actually from the other studies that both options are valid and they really work.
Excuse me, Dr. Hussam and Dr. Sabri, I have a question. I cannot type in the Q&A. I am Ahmed Gavallah. In the standard traditional treatment before the total neoadjuvant era and short course era, we have some patients after the neoadjuvant chemoradiotherapy, we have patients who develop pathological complete response after surgery. These patients in a lot of institutes escape chemotherapy as an adjuvant treatment. We have some data from England specifically that they can escape the adjuvant chemotherapy in these patients. If we give these patients the short course, the total neoadjuvant, so we expose some patients that can escape the chemotherapy due to the short course radiotherapy or the total neoadjuvant protocol. What do you think about this group of patients who are pathological complete responders to radiotherapy?
Thank you for the question. I agree with you. The problem is that we cannot identify the good responders beforehand. We cannot, we don't have any modality that could give us this answer actually before we start the treatment. The other thing is that the chemotherapy, the adjuvant chemotherapy role is really questionable because we don't have solid data where we can apply the adjuvant chemotherapy for specific population of patients. They say that probably T3, T4 patients or patients with high risk, but those patients, some of them, they respond very well to chemoradiotherapy without even adding the adjuvant therapy. And those patients are included in the trials of watch and wait without adding any adjuvant therapy to them. So we really miss this information, and we don't know how to stratify patients according to the response to chemoradiotherapy.
Dr. Hassan, I want to add something about the very nice question from Dr. Ahmed Gavallah about omitting of surgery for some patients who are achieving pathological complete response. I think without doing a surgery, you cannot have full data about pathological complete response. You have only clinical response, MRI, and endoscopy. And I think MRI, I tailored the practice to have a specific MRI with extramural invasion scoring index to assess the patient are good responders radiologically by after concurrent chemoradiation, either long course or short course plus chemotherapy. And based on these data, you can go to the patient, you have a radiological complete response, you can go for no surgery and follow up. But taking in your account that there is a 33% failure, local failure rate for those patients who didn't do surgery. And the failure is mostly 80% of them are recurred locally, and they can be operated in the first recurrence. I think no surgery in the upper trial per se. You can highly select the patient with no surgery, and you should keeping them under close follow-up, because still the patient have no surgery. They have a risk of higher risk for recurrence and also has a risk of distances. I think we are going to ask Dr. Hussam about a little bit tricky question about the patient who presented upfrontly with a rectal mass with a single hepatic focal lesion. In the colorectal, in the colon specifically, the answer is very clear. You can go for a neoadjuvant treatment and go for resection for the colonic mass and operate the hepatic focal lesion. In the rectal cancer, you can operate these patients by arterial resection. But what's Dr. Sam, what's your opinion about the positioning of radiotherapy for these curable patients? You can resect the rectal cancer and you can resect also the single mets. What's the positioning of the radiotherapy? If you have starting for focus for those patients and after chemotherapy, you have a very good response. Do you prefer to give radiotherapy before surgery or after surgery? Or do not give anything?
Thank you very much for this excellent question. Actually, I think this is one of the debates that happens every day, actually, in our practice. Usually, there is no single right answer for this question. We start, as you just mentioned, by offering chemotherapy to test the water, to test the nature of the disease. Some of the patients, they respond very well to chemotherapy, and that's why we become more encouraged actually to treat them locally. I always follow the will of the surgeon. If they are willing to do one stage, resection in the liver and locally, or if they want to do, for example, two-stage surgery to start with the liver or to start locally. And according to the answer of these questions, I might think of each of the modality or options we have. For example, if the surgeon is rushed to do the surgery, I might give, for example, a short course radiotherapy to the pelvis. If, for example, the patient is not ready for surgery and he might wait a little bit after the chemotherapy, I might offer the long course radiotherapy to downstage the tumor in the pelvis. And sometimes we get a discordance between the responses in the metastatic site and the local sites. Some patients, they respond very well to the chemotherapy at the metastatic site, but they fail in the pelvis and vice versa. So it really depends on the situation and patient by patient, decision.
Yes, actually, I faced this debates with one of my patients, and I actually focused for him, and they achieved the near complete response. And I started concurrent by after taking his agreement, I told him that it's not usual way for treatment. I started concurrent chemoradiation long course after finishing 4 cycles of FOX, and the patient go for upfront surgery for excision of the rectal mass, followed by 1 month and excision of the remaining liver metastasis. And actually, I enjoyed the German trial. That's the preoperative radiotherapy is more efficient than postoperative. I think this is still debatable area. for discussion. And concerning downstaging, do you think that some patient with low rectal advanced cancers, do you think that's a concurrent chemoradiation with short course is more beneficial, or do you relate to the long course because of very narrow space between the mass and the inner verge? Do you think that downstaging is highly applicable in the short course, or you stick to the classic way to give him long course radiotherapy? Because many investigators preferring long course for low rectal cancers.
That's true, and most of these evidence come from the trials which looked at the watch and wait protocols. Most of them, they use the long course radiotherapy, and the pioneer in this, Dr. Angelica Haber-Gama in Brazil. She managed actually to increase the PCR up to 48% by adding chemotherapy to the long course radiotherapy. Usually her studies are, we cannot actually say it's rely on these studies very much because the number of patients and the high selectivity for her patients. So I would rather start long course chemoradiotherapy for those patients with low rectal cancer or those with lateral side pelvic wall lymph nodes. To start with the chemoradiotherapy, just to try to downstage the tumor and probably to add chemotherapy before the surgery.
We're waiting for more questions from our dear audience. Until receiving more questions, I want to ask Dr. Hussam about his opinion about adjuvant chemotherapy post total neoadjuvant treatment with short course. Do you prefer to go for more chemotherapy after a patient who achieving near complete response or not achieving pathological complete response for patient receiving short course, then followed by FOLFOX protocol or CAPOX protocol and go for surgery? Do you prefer to give adjuvant treatment for a patient did not achieve complete response or not?
This is a very difficult question, actually, because we still don't have evidence that we can add more chemotherapy to those patients who receive total neoadjuvant therapy. But I believe that I would rather to keep my weapons for those patients if they recur in the future or something like this. The problem of rectal cancer that usually is the distant metastasis, and patients are usually having distant metastasis at 5 years or more, and probably they will need more chemotherapy at that time. So I would I'll be satisfied with the total neoadjuvant therapy and chemotherapy before the surgery.
Yes. Dr. Assam Sinan was raised his hand. He wanted to speak and ask. You can open the mic for Dr. Assam. He asking now. We are waiting for more questions. Kindly type your question in the Q&A, not in a chat room. Yes, Dr. Hussam, till receiving more questions. Do you think that's an upcoming era of COVID era? Do you think that we can go for more benefits?
Assalamu alaikum.
Assalamu alaikum. Dr. Rubna, assalamu alaikum.
دكتور عصام سنان معك.
السلام عليكم.
كيف الحال؟ إن شاء الله بخير. الله يعطيك العافية. Thank you very much actually for this. I thought that it's an open discussion also. Sorry for maybe I should write my. It's just only to highlight a few things here. First of all, thank you very much, Hussam, for the nice talk about and reviewing the background of the rectal cancer. I think the debate is already resolved because I see most of the question is about the chemotherapy, about the downsizing or stuff like the short course is equivalent to the long course. And that's what is my concern actually, because Dr. Hussam presented the data, the direct comparison between the two, and everybody now believes that it is equivalent. And that's our concern as radiation oncologists. Regarding the chemotherapy, yes, I agree. It's really a dilemma. But now with the Rapido trial, when it became as a new adjuvant, it makes a lot of sense. We saw how the difference in almost double in pathological complete response, also the distant mets, which is the main issue now. Everybody agreed that rectal cancer, we are maximizing the local control by total mesorectal excision and radiation therapy, either long or short course. Now the issue is the distant mets, which is, I think, a clever idea to start it in the beginning with the short course, because it will not take time. It, as Dr. Hussam mentioned, maybe a week or so, and then you already the floor for the medical oncologist to start and shrink the lesion very well. With the short course, it's the double effect, and then patient goes for surgery, probably with the minimal disease. We would like to highlight here that those patients are resectable up front, is not non-resectable. So that's what most of the trial involved those patients. Regarding the down staging, probably maybe it's not down staging, stage is already set from the beginning, it's downsizing. Most of the surgeons I met, and even in our institution, they don't believe that long course versus short course will change their mind regarding the surgery. And that demonstrated in some studies. So the surgeon will go with the first presentation. Either he will decide about APR or lower anterior resection. So it makes sense also. I would maybe disagree a little bit here with Hussam regarding short course can be also beneficial in these cases, and you give it time, like 4 8 weeks after, and then you go for surgery. It will give you most likely the same effect. So rectal cancer, a lot of things, but I'm happy to hear that most of the discussion about the medical oncology, like I would be happy if we invited somebody or somebody from medical oncology to share us their opinion. Thank you very much. Thank you, Hassan.
Thank you, Dr. Hussam.
Thank you very much, Dr. Hussam. Actually, Dr. Hussam, he's a strong believer on short course, and this debates actually always happen around the table when we discuss the cases of rectal cancer.
But you resolved the issue, Hussam. You mentioned 30 years about the short course in use in practice. So that's very good. By the way, I started the first short course treatment actually more than 12 years ago when I was in the MAP first with one surgeon who was a believer. I don't know, he told me just immediate surgery after the short course. I told him, why not? So we tried a few patients with this protocol. But as you know, this is not beyond us. It's in the Europe, Scandinavian, as you mentioned, Swedish trial, Dutch trial. All these started with short course treatment for hundreds of patients without any significant complication. And that's what's matter, as well as very important, it's equivalent to the long course and the results. My belief why I go with the short course, because it's easier for the patient. It's just only 5 days, as simple as that, as well as in a heavy, as you know, Hussam, institute, like our institution at university, we have a busy center, so better will save some time for other patients. That's kind of my humble opinion. Thank you very much.
Thank you, Professor Dr. Osam, about your great opinion. As also, as a believer in the role of short course radiotherapy, I am totally agree with you that the short course is now the elegant selection for us. Especially even before TNT era, we have many trials that postpone the patient after short course to have more time, to have more PCR in the patients. So we have actually in the Rapido trial, we are waiting for 4 months after finishing of short course. I think even without giving a chemotherapy or needing for a medical oncology input in this era, I think waiting after short course for 8 weeks in many trials, having more PCR for the patients to have more time to cell death. We have another question from Dr. Lubna Zahra, Professor of Clinical Oncology in Shams University. Thanks for your input about the current situation of COVID. Short course radiotherapy is required, in your opinion. Who is the best candidate for rectal carcinoma for short course preoperative radiotherapy? I think this is a very important question about the selection criteria for the patient who are gaining a more benefit from short course without comorbidities. Dr. Hussam, what's your opinion about selection of the patient for short course?
Yes, I would like just to highlight the difference between the short course alone and the short course with chemotherapy, as in the Rapido trial. If I'm a believer now of the short course, I think the strong point in the Rapido trial is the chemotherapy, adding the chemotherapy, because we know that short course and long course do the same, probably with some superiority in the long course. But when it combines with chemotherapy, it is way superior in terms of PCR and distant metastases. So if I'm going with the chemotherapy and Rapido protocol, I would choose, I will have no selection criteria actually for patients. I will be using the Rapido trial for all patients. But if I don't have the option of chemotherapy, then I'll have my own selection criteria, which is, as we just mentioned, the low rectal cancer and patients with N2 disease, or those patients with lateral pelvic lymph nodes. I would prefer to go with the long course chemoradiotherapy for those patients.
Yes. Do you think, Dr. Hussam, about the patient with low rectal cancer with not obstructed, but with a very narrow rectal lumen? Do you think that's starting in the Rapido design to start 5x5 fractions? It is suitable, or to go for firstly to go out of Rapido design and give him a chemotherapy firstly, followed by 5x5 fractions? Do you think in this scenario, we have in our clinical practice, we are facing these patients frequently, the patients with low rectal cancer with a stenotic segment in the rectum and not obstructed, and prefer to give him a preoperative treatment, either short course or long course. In era of short course, do you prefer to go with the Rapido trial to give 5x5 for FOLFOX, or give him FOLFOX firstly, followed by 5x5 radiotherapy?
Well, I think we don't have a specific answer for this question, though it is a very excellent question. Even if I'm thinking about the radiotherapy, actually the benefit of the radiotherapy will take a little bit long to be shown on the patient as an impact of radiotherapy to resolve this stenotic issue or stenosis. But what I would think about for those specific patients is how to relieve actually this stenosis, either by we do rectal, sometimes we do diverting colostomy, sometimes we relieve this obstruction, and then we start to think about what's the best management for those patients. Usually for the long segment tumors, I would be more concerned about the downstaging of the tumor and to enhance the resectability of those patients. So again, I would use the short course if combined with the chemotherapy. Otherwise, I will use the long course chemorad.
Yes, I think we are going to end this elegant session. Thanks for Dr. Hussam Hagazi about Professor Dr. Hussam Hagazi about his elegant presentation about a very important issue in our daily practice, short course versus long course. Thanks again for Dr. Ahmed Gaballa, Professor of Clinical Oncology at Shamsi University, for his invitation to us to share this very scientific and very elegant meeting. Thanks for attendance. Thanks for our colleagues. And hope to meet you again, not virtually, but personally, inshallah, في أقرب وقت. شكرا يا جماعة.
Thank you very much. Thanks a lot. شكرا.
Thank you. Thank you.
Thank you, Professor Sabri. Thank you, Dr. Hussam. Thank you very much for this presentation. Thank you. By this, I would like to end the session, and I hope we meet, inshallah, soon in further educational sessions, inshallah.